did our presentation on a carcinoma case study. Our members were Megan Schmidt, Megan Hale, Maddie Henry, and myself, Jenny Riley. The contents of our presentation are a brief case description, an overview of the voice disorder, anatomic, physiologic, and neuroanatomic information as applicable for this case study, incidence and prevalence of the disorder, and nature, signs, and symptoms of carcinoma. So the case description involves case history, assessment findings, treatment results, and a brief discussion of the disorder. So carcinoma, our case history information for this particular report involves a 50-year-old male patient who came to our clinic 17 years ago. He presented with a complaint of swelling on the thyroid, and right after that he underwent a total thyroidectomy and neck dissection with the diagnosis of thyroid papillary carcinoma. During the assessment at that time, they found a 4 by 3 centimeter sized hard mass, which was found during palpation on the left side at the level of the cricoid during physical examination. An endoscopic examination of the larynx and vocal cord movements were normal. Ultrasonographic examination revealed a solid mass invading the laryngeal structure. A fine needle aspiration biopsy was taken from the mass, and it was found to be compatible with thyroid papillary carcinoma. A neck CT showed a malignant mass lesion extending to the larynx in the cranial direction in the thyroid compartment and destructing cricoid cartilage and thyroid cartilage. So the patient was scheduled for a laryngectomy after this evaluation, and his full diagnosis was papillary carcinoma invasion of the thyroid and cricoid cartilages. So his treatment was surgery, particularly it was supracricoid laryngectomy. So for the surgery, we went through, the entry point was through the previous thyroidectomy incision, which was done 17 years ago. So we took an excision of infrahyoid muscles, which were invaded by tumor tissue, and we also excised the left side of the thyroid for the 5 millimeters of cricoid tissue that was invaded by tumor. During the laryngectomy, the upper right half of the thyroid cartilage that was not invaded by tumor, including the superior cornu, was shaped and sutured to the site of the resected part of the cricoid. The treatment results after the laryngectomy involved narrowing of the laryngeal air passage and local recurrence, and they were not detected during the 3-year follow-up period after the laryngectomy. The control CT scan of the neck showed no evidence of recurrence of the tumor, and the cartilage used for reconstruction was found to be in the appropriate position, allowing an adequate airway passage. So the next slide shows some pictures of what was done. So the first picture shows the 17-year follow-up after the first thyroidectomy. So you see a prominence there on the right side, which shows the left cricoid cartilage prominence where the tumor was located. The middle picture on the slide shows the reconstruction as it was done. So the arrow is pointing to the cricoid cartilage, and what is placed there during the surgery is actually a section of the thyroid that was used to reconstruct the cricoid. And then the third picture just shows post-surgery, a picture of an open airway passage after the structures were reconstructed. So as for discussion for this case, the surgical options for thyroid cancer invading the larynx should be evaluated to decide the most appropriate choice for the particular patient. Use of near total laryngectomy was not appropriate because of a presence of a permanent tracheotomy that occurred 17 years prior to him coming to see us. The laryngotracheal invasion is a factor that worsens the prognosis in thyroid cancers. Although the surgical option is controversial, the technique that was used is effective on quality of life. While cricoid and thyroid cartilage involvement in the presented case is an indication for total laryngectomy in primary laryngeal cancer. This allows partial laryngectomy in thyroid cancer invasion. We think that partial laryngectomy, according to the involvement site and the appropriate reconstruction techniques, should be used for thyroid cancer that invades the larynx.
All right, so now we're going to go into an overview of the full voice disorder, which includes the risks, signs, and symptoms. And here is a picture of just the part of the tumor that was going into the thyroid from the cricoid cartilage. All right, so an overview of the disorder. Cancer cells, which are mostly squamous cells, grow in the laryngeal tissue, which affected the thyroid and the cricoid in this case. Some of the risks are tobacco and alcohol abuse, and symptoms are sore throat, earache, pain with swallowing, and a lump in the throat or neck. And these lumps can be visible from the outside if they're big enough. Signs are enlarged lymph nodes, swelling, and thyroid nodules. Hoarse, strained vocal quality, and possible changes in loudness and pitch are part of the reason why we see these patients as SLPs.
Okay, and then we get into the categories of anatomic, physiologic, and the neuroanatomic information particular to thyroid cancer and this case study. And so some of the prominent anatomic features for thyroid cancer is that it is a form of endocrine cancer that develops from the tissues of the thyroid gland, which was pictured in this slide here, kind of below the thyroid cartilage itself. The red kind of fatty mass is your thyroid gland. The thyroid gland, as I said, located below the thyroid cartilage, and it encompasses two lobes on the right and left, which are connected by a fibrous bridge called the isthmus. Okay. For more of the physiological information for thyroid cancer, that relates to the thyroid gland produces several important hormones, including the thyroid hormone, which is involved in controlling body temperature, weight or metabolism, energy level, and heart rate. And the thyroid gland is also in charge of producing calcitonin, which helps the body use calcium. Parafollicular cells in the thyroid produce the thyroid hormone, and the pituitary gland in the brain controls the amount of thyroid hormone that is produced by secreting thyroid stimulating hormone, or TSH. DNA mutations can occur spontaneously or in response to an environmental exposure or toxic substances and alter the normal thyroid cells, which is kind of goes along with the cause for thyroid cancer. The genetic changes cause the cells to multiply very rapidly, which disrupts the endocrine regulatory capabilities. Then we get into more of our neuroanatomic structures. So the endocrine system, which includes all the glands in your body that make hormones, and the endocrine and nervous systems communicate with one another via the hypothalamus, which regulates when hormones need to be produced and through which of the glands that make up the endocrine system. And more specifically, the pituitary gland, which is a tiny organ the size of a pea, found at the base of the brain, is considered the master gland of the body, as it's responsible for producing and directing the majority of hormones traveling throughout the body and stimulating other glands to produce hormones. And we get kind of more of an in-depth view of the pituitary gland, which, as you can see, is right next to the thalamus and kind of the brain stem, which is in charge of regulating a lot of the features within the body and the hormones in the body.
Okay, so now let's go into the incidence and prevalence of this disorder and how many people have it. So incidence would be 1.2% of men and women will be diagnosed at some point in their lifetime worldwide. 14.5 per 100,000 people diagnosed per year. And then of those, only 0.5 per the 100,000 will probably die within the year. And 3.1% of all cancer cases are thyroid or cricoid cancers. And the prevalence as of 2015, approximately 765,547 people had it in the USA. Estimated new cases in 2018 will be 53,990. The survival rating in the past 5 years has increased to 98.1%.
Okay, next we're going to look at the nature and go more in depth in the signs and symptoms of this type of cancer. So, the papillary thyroid carcinoma, it presents as either follicular or papillary, and this one is papillary, and the majority of the cases are papillary. So, papillary carcinomas are highly curable most of the time, and they are easy to treat and respond well to therapy. Over 80% of patients in the past 20 years had tumors that were less than 2 centimeters in diameter, which just kind of reinforces that they're easy to treat. And it also indicates that it was caught in an early stage, which makes treatment much easier. The prognosis for this type of cancer includes many factors, such as the patient's age. There's a better prognosis if the patient is less than 45 years of age. The histologic grade, so what the tissue of the cancer looks like, if it's well differentiated or poorly differentiated. The extrathyroid extension, which means if the cancer extends to outside structures, so if it extended into the trachea or something. And then the tumor size. So the larger the tumor size, the greater likelihood of a recurrence even after the tumor is removed or treated. And some more signs and symptoms. Some signs are that you will discover intrathyroid nodules during imaging, such as an MRI. You might not even be getting imaging to look specifically for the nodules. It could be during imaging for something else. You can palpate and feel a lump through the skin. There are swollen lymph nodes in the neck, increasingly hoarse sounding voice, and airway obstruction due to the invasion of the tumor into the trachea. Some symptoms. One important thing to note is that there are usually no symptoms when the cancer is initially diagnosed. The symptoms don't usually occur until the tumor has invaded adjacent structures. And these symptoms include feeling of pressure in the neck, choking sensation, feelings of hoarseness, hemoptysis, which is the coughing up of blood, pain in the neck and throat, and difficulty breathing and or swallowing. And these are our references.